I'm going to mainly focus on the treatment of depression. However, I'll cover very briefly bipolar disorder as well. A clinical diagnosis of depression is based on these criteria. So the patient must have at least one of a depressed mood or apathy or loss of interest. And so if they don't have one of these, then it's not classified as depression. And then as well as one of those, you need to have at least 4 of the following: weight or appetite changes, sleep disturbances, psychomotor agitation or retardation, fatigue, guilt or feelings of worthlessness, and executive dysfunction, as well as suicidal ideation. Here we have a few of the possible risk factors for depression. So you're about 2 times as likely to have depression if you're a woman. The peak onset with age is between 20 and 40 years. Family history, so you're 1 to 3 times higher risk with a positive family history. Postpartum, so there's an increased risk within 6 months of childbirth, as well as negative life events. So this is if you've had some sort of traumatic episode, for example, and it's a reactive response. And another one is marital status. Now this one's a little bit interesting because it varies between males and females. So obviously if you're divorced or recently separated, this carries an increased risk of suffering depression. There's also married males have a lower risk, so it's actually protective for them, which is the opposite for females. So females who are married have a higher risk of depression, which is quite interesting. So the general theory or hypothesis around the pathology of depression is that there's an upregulation of the postsynaptic serotonin or 5-HT and noradrenergic receptors. And this upregulation is due to an abnormally low levels of noradrenaline as well as serotonin in the synaptic cleft. And this will result in an upregulation of those receptors. And so the therapy is generally aimed at down-regulating these receptors. And we do this through a number of mechanisms, mainly through increasing the synaptic concentration of dopamine and 5-HT. The first class of drug that we're going to look at are the tricyclic antidepressants, or TCAs, and the core drug is desipramine. So desipramine is going to block the reuptake of primarily noradrenaline, so it'll block this transporter, as well as 5-HT. And so this is going to increase the synaptic concentration of both of these drugs. Now these will both respectively act on specific postsynaptic receptors, and if they're continually going to activate these receptors, we're going to get a downregulation of both receptors, which will mean that any concentration of either of these drugs that are going to enter the synapse will then have a greater effect on the postsynaptic neuron. Unfortunately, they also tend to act on other receptors, and most notably the muscarinic receptors. And so you're going to get a whole host of adverse effects associated with muscarinic receptors. So sludge, which is a good way of remembering the actions of cholinergic neurons. So that's salivation, lacrimation, urination, defecation, GI upset and emesis, and so you're going to get dry mouth, blurred vision, urinary retention, and constipation. The person isn't always going to get all of these effects, but it's possible for them to get those. They're also going to act on H1 receptors, so histamine receptors, and this will lead to blockage of these receptors will lead to sedation. And they're also going to act on alpha-1 adrenoreceptors, and this will lead to dilatation of these blood vessels, which will lead to hypotension. And so these are the major adverse effects. We have sedation as a result of blockage of the H1 receptor. We have hypotension as a result of blockage of the alpha-1 receptor. And then we also tend to get cardiac arrhythmias as a result of the antimuscarinic effect and the blockade of the sodium noradrenaline uptake. So these cardiac effects are quite common with the therapeutic dose, and so they can have suicidal effects, and so you need to be really careful when prescribing these tricyclic antidepressants. Our next drug is monoamine oxidase inhibitors. Now, monoamine oxidase can be classified into MAO-A and MAO-B. And these are both each responsible for the metabolism, the presynaptic metabolism of 2 or 3 different enzymes. So MAO-A is responsible for noradrenaline and 5-HT or serotonin, and MAO-B is responsible for dopamine. And so tranylcypromine is a non-selective inhibitor of both MAO-A and MAO-B. However, in depression, we only really want to target MAO-A because it deals with noradrenaline and 5-HT. So tranylcypromine is a non-selective inhibitor, so MAO-A and MAO-B, and it's also irreversible. So this means that we get a few adverse effects that we don't see in reversible MAO inhibitors. And so it's going to inhibit MAO, and this will lead to increase in concentration of all of these neurotransmitters, and then as a result of being an irreversible inhibitor, we get what's called a cheese reaction. And this might sound a bit weird, but I'll explain it to you. So irreversible MAOs will inhibit the MAO present in the gut and the liver, which will allow for unmetabolized dietary monoamines, such as tyramine, which is present in cheese, to have free access to the body. And this will result in an overload of noradrenaline and 5-HT stores from the nerve terminals. And so if you have a huge uptake of this, it'll mean that you have adverse effects such as hypertension as a result of an increase in noradrenaline. And as a result of this, you get what's called a hypertensive crisis, and that is only seen with tranylcypromine, which is an irreversible inhibitor, and so we don't generally prescribe these drugs, but instead we'll prescribe what's called reversible inhibitors of monoamine oxidase, or REMAs. So our core drug for REMAs, or reversible inhibitors of monoamine oxidase, is meclobamide, and this not only is reversible, but it also selectively targets MAO-A, And as we've already discovered, this means that we're only going to inhibit the degradation of noradrenaline and serotonin, or 5-HT. And so this means that not only do you avoid the hypertensive crisis, but also you have a lot less adverse effects. And so in the irreversible monoamine oxidases, I should have mentioned that people generally suffer insomnia, postural hypotension, atropine-like adverse effects, as well as sexual dysfunction. However, with the reversible inhibitors of monoamine oxidase, with moclobemide, our only real adverse effect is insomnia, as well as a little bit of nausea, which is expected with most drugs. And you don't get any other postural hypotension, hypertensive crisis, or atropine. And so the main use of these drugs are for anxiety as well as panic or phobia. Our final and probably the most important class of drugs to treat depression are our selective serotonin reuptake inhibitors, or SSRIs, and the core drug is fluoxetine for this class. So, as the name suggests, they selectively inhibit the reuptake of serotonin. And so, just like most of the drugs that we've discussed, they're going to block this reuptake, which will lead to an increase in synaptic concentration of 5-HT. And as a result of this, the receptor that's on the postsynaptic neuron is going to be down-regulated. And I mentioned at the very start that the pathology of depression is thought to be as a result of an abnormal upregulation of these receptors, which is due to a chronic low concentration of serotonin as well as noradrenaline. And so if we're able to block this reuptake transporter, we're going to cause an increase in concentration of 5-HT, which will result in a desensitization or downregulation of this receptor. Because it doesn't work on any other receptor, it means that you don't get any chronic adverse effects. However, there are some acute adverse effects that are very serious, and so they must be taken into consideration before prescribing. And they're mainly due to this initial huge response of an increase in 5-HT. And so you get symptoms like anxiety and panic attacks, as well as sexual dysfunction and GI upsets. And because these are very serious adverse effects when you're already treating someone for depression, we tend to co-administer these drugs in the initial period to combat these adverse effects. And so we might add in a MAO inhibitor, as we've already discussed, or potentially a natural herbal therapy such as Sir John's wort. But without a doubt, these SSRIs, and notably fluoxetine, is our number one therapy for depression. So I'm going to quickly touch on bipolar disorder. And this is characterized by sort of cyclical variations in a very high or euphoric mood, or sometimes called a manic episode, and then times when the person is feeling quite depressed. And so the therapy used for bipolar is generally lithium, which is a mood stabilizer. Unfortunately, it's not all that effective in the rapid cyclic bipolar disorders, so it's more effective in those slower cycles. And people often require a drug to treat the depression when they're in that depressive phase. And lithium is thought to enhance the uptake of noradrenaline and 5-HT, which is the opposite to the antidepressants. It has a number of adverse effects: tremor or hyperactivity, nephrogenic diabetes insipidus or polydipsia, polyuria, as well as nephritis or glomerulopathy. So it's generally those renal adverse effects, and that also includes edema. Another two drugs that are often used in the treatment of the very acute phase of the manic aspect of bipolar disorder is valproate as well as carbamazepine. And these, as we've already discussed, are generally involved in epilepsy. But these two drugs can be used for people who are refractory to lithium, and also people who cycle rapidly between manic and depressive episodes of bipolar. So they're generally the two drugs. Lithium is the first line therapy. It's a mood stabilizer for non-rapid cycling, although we have to be conscious of the renal adverse effects associated with them. And then there's valproate or carbamazepine, which are generally the acute episodes with rapid cycling.